You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for May 8th, 2020. This week, we're talking COVID, a bit more cardiology, including angiotensin blockade, TAVR, and stroke care. First, some U.S. numbers for COVID. When I recorded last week, there were 1.1 million cases. Today, there are 1.26 million cases. The rate of rise last week, 1.25x. This week, 1.14x. Again, a decrease. Notable, too, is a huge gap in testing. The United States has performed just over 8 million tests. No other country is close. Now, when I recorded last week, there were 63,000 deaths in the U.S., and today there are 75,000. The rate of rise last week was 1.25x, but now it has decreased to 1.19x. But the truth is, the death rate in the U.S. from COVID seems fairly steady. Now some thoughts on the global picture with COVID. We're now at just under 4 million cases worldwide, and 1.3 million people have recovered. Now, one place I'm specifically worried about is Brazil. I talked to a colleague there, and he told me that places in Brazil could very well overwhelm hospitals. So to my listeners there and in South America, I'm thinking of you. Another place that intrigues me is India. Only 53,000 cases and 1,800 deaths. Belgium, a small country, has 4 times more deaths than India. I ask, why is that? And it's facts like this is what makes learning about this novel virus so fascinating. The uncertainties here far outweigh certainties. Okay, 2 brief comments, then on to cardiology. I read a wonderful review of SARS-CoV-2 evolution and pathology in Nature, and I'll link to that. I was struck by this line from a prominent scientist. He was quoted as saying, by far the most likely scenario is that this virus will continue to spread and infect most of the world population in a relatively short period of time. Afterwards, the virus will continue to spread in the human population, likely forever. Another prominent voice in this crisis, Dr. Scott Gottlieb, took a similar view in the Wall Street Journal this week about COVID-19. Quote, hospitals and public health systems will have to contend with persistent disease and death. He called this a cruel new normal. I think the long-term nature of this problem is now being recognized. We seem to be through the danger of overwhelming hospital systems, at least here in the U.S., and will have to settle in to a new way of living for the next year or two. An indication of that was ESC's decision to move their meeting to virtual. ESC is in late August, early September, which seems like a long time from now. But there's just no way we're going to have large gatherings in indoor places this year, and I think maybe not even next year. Second COVID comment pertains to testing. The Heart.org Medscape Cardiology published 2 wonderful columns this week on testing for COVID-19. My friend Anish Koka, a thoughtful cardiologist who actually still does house calls in Philadelphia, wrote a piece on why we can't test our way out of the COVID crisis. It's provocative because lots of key opinion leaders advocate for test and trace as a way to more safely open up society. Anish has a great review of testing basics, but then ends with a lesson on how observational data can mislead. So there's a well-circulated scatter plot going around which purports to show how testing relates to control of the epidemic. Someone drew circles around countries and added labels, as if to say, see, these countries that do lots of tests have fewer issues with COVID. And it's compelling. It makes for a great story. You can tell people it will be safe when we have more tests, and of course people feel better. But it's wrong. Another friend of mine, Andrew Foy, also a cardiologist, actually plugged the data in his computer and did logistic regression. He looked for a correlation, and he found almost no correlation. So I urge you to take a look at Anisha's column. It makes the podcast because this podcast worries a lot about making causal claims from observational data. It's not impossible, but it's hard. Which brings me to another column on testing, this one from two brilliant academics, Drs. Jha and Murthy. Their column addresses what everyone is talking about, seroprevalence studies. Rare is it when a column on specificity and sensitivity makes this much sense. The authors show that the much-maligned Santa Clara study from Professor Ioannidis actually used a darn good antibody test. The importance of this column transcends the overly harsh critique of Professor Ioannidis or the specifics of how seroprevalence informs the infection fatality rate. Crucially, if you read this column and save it and reread it, it yields valuable information on the interpretation of medical tests. And herein is why COVID is not merely a virology or epidemiology or economic problem. It makes us think lessons learned in this disease and its therapy will make us all better clinicians because it makes us better thinkers. One problem medicine had before COVID-19 was that it was siloed. Cardiologists stayed in cardiology, oncology and oncology, EPs and EP. Since this is a novel virus with a clearly novel therapy, it forces us all out of our silos, and that, I think, is a good thing. Second topic today are angiotensin studies in COVID-19. Once again, the brilliant Sue Hughes has distilled the essence of 4 complicated observational studies on the relationship of angiotensin blockade and COVID-19. Recall that this virus attaches to the ACE2 receptor of cells, and that finding, plus studies that show that patients with hypertension, diabetes, and cardiometabolic risk factors seem to have a higher risk, got people thinking about causal connections. So the first observational study in New England analyzed data from about 9,000 patients who had either died in the hospital or survived to hospital discharge. This study found that neither ACE inhibitors nor ARBs were associated with an increased risk for in-hospital death. In fact, ACE inhibitors were associated with a significant reduction in mortality. Second study, also published in New England, compared about 6,000 patients with COVID-19 to 30,000 matched controls, and again, neither ACE inhibitors nor ARBs were associated with the likelihood of SARS-CoV-2 infection. Third New England observational study from New York Langone used a Bayesian analysis, and they did propensity matching and found no positive association for any of the analyzed drug classes for either a positive test or severe illness. The fourth study from Cleveland Clinic, published in JAMA Cardiology, found no difference overall for testing positive among patients taking an ACE or ARB in comparison with those not taking such medications. However, this team did a secondary analysis that suggested a higher likelihood of ICU admission in patients who were taking an ACE inhibitor, but no such difference was observed among those taking ARBs. That raises the possibility that the two drug classes may have different effects in patients with COVID. The problem here is that in the main analysis, with much larger numbers of patients admitted to the general ward of the hospital, not just the ICU, found no differences in the drug classes, so it could be small numbers. But here's where you can appreciate good journalism. Sue reaches out to two experts. One says you should not totally dismiss the possibility of a differential drug effect because a large VA study also reported a similar finding. The other expert she talks to points to a hypothesis which suggests that direct viral infection of endothelial cells expressing ACE2 receptors may explain worse outcomes in patients with cardiovascular comorbidities, which is of course important because it gives a rationale for using therapies to stabilize the endothelium, particularly with anti-inflammatory or anti-cytokine drugs, ACE inhibitors, and even statins. I highlight this topic because the more I listen to ICU and hospital clinicians who are taking care of these patients, the more I have come to think that there is something special about the vascular effects of this virus, something different perhaps than other respiratory viral infections. Third topic today, cardiology. We have to talk more about TAVR. Here's a typical case scenario. A patient with metastatic breast cancer but is stable on chemotherapy. She can't walk across the house now because of dyspnea. She has severe aortic stenosis. Now what? There will surely never be an RCT of cancer patients who may benefit from cardiac interventions. In fact, most cardiac RCTs exclude such patients. Observational studies, therefore, would be all that we have, and alone each study would have large error bars, plus the issues of selection bias. So this is where a meta-analysis could come in. By combining similar studies, a meta-analysis can find a point estimate that has a narrower confidence interval or error bars. This is exactly what my friend Dr. Ahmed Bendari from Banha University in Egypt did. Along with 3 other co-authors, the group looked at efficacy and safety outcomes in patients with severe aortic stenosis and active cancer. Their search found 3 studies, including more than 5,000 patients, about 7% of whom had active cancer. And when they combined these studies, they found that TAVR in patients with cancer is associated with similar 30-day outcomes, but potentially worse 1-year outcomes, hazard ratio of 1.71. compared with those in patients without cancer. So they did a secondary analysis, and the 1-year all-cause mortality appeared to be dependent on the stage of cancer. They published their paper in Open Heart, and I liked their final conclusion sentence. They say, involve an oncologist in decision-making. I think these are important studies because as cancer therapies get better and better, we will increasingly have to consider how best to apply invasive cardiac procedures to these patients who are living longer with cancer. Now, one warning, based on my experience, oncologists often have a quite optimistic view of prognosis. My theory is that optimism is just built into oncologists. So another thing I might consider in patients with cancer and aortic stenosis, and of course I am biased here, when in doubt, you could also consider asking a palliative care professional. My wife, Stacy, says that palliative care docs are pals for people with serious disease. I think we should use them more, not less. Final topic today is neurologists are learning from cardiologists. Now, I am embarrassed to say this because it makes me seem old. Don't discriminate against old people. I remember when primary PCI came into being. Before PCI, for STEMI, there was thrombolytic therapy. Patient with a STEMI would present and get lytics, and then if they failed to reperfuse, they would go to the lab for PCI. But then as we got better at PCI, we thought, let's just give lytics first. Why not? I mean, STEMI comes from thrombus, so let's bust up the thrombus and then mechanically open the vessel. Of course, more would be better. Well, this turned out to be worse than PCI alone. Less was more in STEMI. How did we know? We did RCTs. In acute stroke care, it has always baffled me that patients eligible for mechanical thrombectomy, a small number of patients with stroke for sure, but first they get lytics. Now, I won't relitigate the extremely dubious nature of lytic therapy alone in patients with acute stroke, but finally, the stroke community got around to testing the notion of using lytics before mechanical thrombectomy versus mechanical thrombectomy alone. New England Journal of Medicine published the direct MT RCT, 41 centers in China, about 1,600 patients screened to enroll 650, half to either thrombectomy alone or the other half to combination lytic plus thrombectomy. It's a non-inferior design. The primary endpoint was a change in modified Rankin scale, which goes from 0 to 6. The control arm here is the combination therapy, the established care. The challenger was thrombectomy alone. The results were that thrombectomy alone was non-inferior to the combined lytic plus mechanical thrombectomy arm with regard to the primary outcome, the adjusted common odds ratio 1.07. Now that did meet non-inferiority. The median modified Rankin score of both groups was 3, not changed. The mortality at 90 days was 1.1% lower in the thrombectomy alone arm, 17.7 versus 18.8, but that difference did not reach statistical significance. Then NIHSS score at 1 week was 8 in both groups. There were no major differences in adverse events. However, in imaging measures, which remember are surrogate outcomes, not clinical outcomes, combination therapy looked to be better. Now I have to tell you, more is better than less dies hard in medicine. The editorialist questioned the non-inferiority on the basis of non-inferiority being too generous. The confidence intervals, the editorialist said, did not exclude a benefit of approximately 20% in the combination therapy group. Another thing the editorialist struggled with was why better reperfusion metrics in the combination arm did not lead to better outcomes. The lesson, I think, here is one that cardiologists know well. You don't want to completely dismiss surrogate measures, but in the end, patients care most about clinical outcomes, say survival and function, less so about brain imaging. The editorialist makes clear that this trial should not change guidelines. Keep giving the combination. He rightly says that one trial should not change established practice. And that, I think, is a very wise statement, though it's not often followed in cardiology when it comes to new devices and drugs. I'm thinking sacubitril valsartan and icosapent ethyl, for instance. But at least this trial establishes equipoise in the two arms, and there are 3 similar RCTs ongoing. I may be wrong, but put me down for predicting that giving lytics before thrombectomy and stroke will go the same way as giving lytics before PCI for STEMI. Finally, as I record this podcast this morning, late-breaking clinical trials from the Heart Rhythm Society meeting are set to present virtually. Next week on the podcast, I will have news on those late-breaking trials. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to tell a friend, give us a rating, or even write us a review. It really helps other people find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.